Hi, my name is Thompson Carroll, and I'm going to talk to you about advanced abdominal aortic ultrasound over the next hour. This is a great topic. I'm really excited to be talking about this. It's something that we worry about on a daily basis, working in the emergency department. If you get good at this, it can be life-saving. We're going to get into some very basics and then delve into some more advanced topics later on in the lecture. So let's get started. I don't have any disclosures to make at this time. This is a scary sight. This is a big abdominal aortic aneurysm, over 9 centimeters. I'm fortunate to work in an emergency department where we see a great variety of pathology, and we tend to see a ton of cardiovascular pathology. This manifests in the usual cardiac stuff, but we also see a ton of AAAs. For some reason, it seems like we're seeing more and more of these. Probably has to do with the population aging, etc. But we've spent a lot of time looking at these studies and kind of picked up on some interesting tidbits. So again, we're gonna work on looking at these and then trying to figure out some more advanced topics. As I mentioned, we see a ton of these. These are scary. These can be also easy to misdiagnose. This is a case where a patient that came in a couple times, was seen by a number of different local providers and misdiagnosed. A 37-year-old guy with bad back pain. He ended up having an 8 centimeter AAA. I throw this out there because this is the kind of thing, you throw an ultrasound probe on this guy's belly, potentially could save his life, where a lot of people that have seen him prior to your visit with him have not considered this diagnosis and not taken the steps to appropriately diagnose him. Objectives for this talk: we're going to talk about how to do this, okay, basic techniques. I have some pearls I'm hoping everyone can take home with them. We're going to talk about rupture, and this is really the crux of the talk. The advanced topic is detection of rupture. We're going to get into some other more advanced stuff like finding abdominal aortic dissection. Topics: basics, rupture, endovascular repair. We're going to talk about dissection, as I mentioned. We're going to get in a couple pitfalls and ways that this study can be messed up, both ones that I've heard of and ones that I've done. And we're going to get into some future considerations. So let's get moving. This is fairly basic stuff. We all know AAAs are aneurysmal dilation of the abdominal aorta. The easiest definition to remember is if that if that abdominal aorta gets to be bigger than 3 centimeters, then it's considered aneurysmal. If it gets to be bigger than 5 centimeters, maybe more like 5.5, we really worry about the risk of rupture. There are some other kind of more nuanced definitions, but this is, again, the easiest way to remember it. 3 centimeters, AAA needs to be followed. Can 3 centimeter AAAs rupture? Well, sure, but much less frequently than the bigger ones. Again, 5 or 5.5 and above. That annual risk of rupture really goes up, and these are the folks you really got to be worried about. Some more basics. These are common. Studies show somewhere a little less than 10% of adults over the age of 65 have a AAA. That's a pretty scary stat. We also know that ruptured AAAs are bad. Right? Mortality exceeds 80%. The earlier we diagnose these, the earlier they can be cared for in an operative setting, the better that they do. This is another scary stat. Over 80% of patients that present to hospitals with ruptured AAAs don't carry a diagnosis of AAA. It makes this job even harder, trying to pick these needles out of haystacks, and all the folks that we see with abdominal pain and back pain and flank pain, hematuria. We also know that initial misdiagnoses are really common, right? Over a quarter of patients are misdiagnosed initially. Most folks have seen this. This is the patient I took care of a handful of years ago. He was an older guy that came in to his primary care doctor, was being treated conservatively with some NSAIDs and some muscle relaxants. Didn't get any better. Ended up getting some x-rays and then was sent in from x-ray to see us because his back pain wasn't coming from his musculoskeletal system. It was coming from his enlarging abdominal aortic aneurysm. So be careful. You got to keep this on your list when you see folks with the above noted complaints. We also know that your hands, your physical exam, isn't that sensitive, right? As the aneurysm gets bigger and bigger, it becomes easier to detect. It makes sense from a clinical standpoint. But as our population increases in size, BMI goes up, your examination, my examination for AAA, becomes more and more unreliable. This gets us to ultrasound. Right? Ultrasound, looking at abdominal aortic aneurysm, is good. It has been found to do what we want it to do. Now, these studies are not big, they are not heavily powered, but they have shown that it decreases time to diagnosis and time to operative intervention. So if you use ultrasound, you will start making improvements on those time stamps that are important in the care of patients with ruptured AAAs. It's also been shown in a real small study to increase survival to discharge. So there is potentially a mortality benefit to utilizing this technique, this study, in the care of your patients. It is highly sensitive and specific. So if you see that abdominal aorta and there's no AAA in there, well, it's a pretty sensitive test. Right? If you see a AAA and you follow the steps that we're going to outline later in this lecture, it can be pretty specific study. So we're going to get into the scanning techniques here. The two things that I really want folks to focus on are binding the spine and sweeping the aorta. Okay, and we'll get into this in just a sec. Most of the time we're going to be using a curved transducer, curved linear transducer. There's a number of reasons for this. I'm not going to delve into it, but that's really the abdominal workhorse probe, as most of you already know. We're going to start in the transverse plane. Okay, indicator notch is going to be the patient's right, and we're going to find the vertebral body, find that spine. Okay, so this is, drop that probe down. This is what we'll see. You got your curved probe up here. Indicator notch is going to be, again, towards the patient's right, and we're going to see vertebral body pop in. Once we find that vertebral body, we know the vascular structure that lies on top of the vertebral body on the patient's left is going to be the abdominal aorta. Okay? If you don't find the vertebral body, there's a chance you're not looking at the abdominal aorta. So when we teach our residents how to intubate, the first step we tell them is find the epiglottis. So epiglotoscopy first. Abdominal aortic ultrasound is find the spine first and find the aorta after you find the spine. Okay. Here's the aortic sweep. So we found the spine, we've scanned proximal to distal down to the bifurcation in the transverse plane. And we can say fairly confidently that this patient does not have an abdominal aortic aneurysm. Okay, and you can follow that spine along down here. There's your abdominal aorta sitting right on top, and it bifurcates. In my opinion, once you've swept that abdominal aorta in the transverse plane and you don't see a AAA, you're done, right? If you're doing a rush exam or whatever mnemonic you want to use for the ultrasound survey of the critically ill patient, you can march on to your next modality. If you find a AAA, you need to be able to turn sagittally on it, okay? And there is reason for it. So here we've taken our curved probe, we've pointed the indicator notch towards the patient's head, and we're imaging that abdominal aorta in the sagittal anatomic plane. So this is what we see. We'll see the aorta going in a cephalocaudal direction. You see the celiac axis take off here, the SMA take off here. Okay, and this operator has measured the abdominal aorta right here. So this is actually a very important view, and this has to do not with what we do, but what the vascular surgeon has to do, has to plan for when we call them about these patients. When we take care of these folks, we make the diagnosis, we do the initial resuscitation, we call the right folks, i.e. vascular surgery, and our job's done. We high-five each other and the patient gets whisked off to the OR. Obviously, the vascular surgeon's job is just starting. Or he or she is thinking about operative planning, where this aneurysm is, what the best way to get there is, and what the best way to fix it is. So the location of the aneurysm is really important to the vascular surgeon. So if that aneurysm takes off and involves the renal arteries, then this surgery is going to be much different. Okay? Involvement of the renal arteries makes this much more complicated. There's a lot more going on in terms of what they have to do to appropriately fix the abdominal aortic aneurysm. If the aneurysm is infrarenal, meaning it does not involve the renal arteries, they can make an abdominal incision. So midline abdominal incision and get down to the aneurysm through that approach. If it involves the renal arteries, they have to take a retroperitoneal approach. So being able to determine whether or not the aneurysm involves the renal arteries or not is important. Now, this is tricky to do. Finding the renal arteries on bedside point-of-care ultrasound can be tricky. But we know almost everybody's renal arteries take off within 2 centimeters of the SMA. So to go back to this image, we see the takeoff of the SMA here. Those renal arteries are going to be popping out somewhere in this area. So if an aneurysm was going to take off down here, we'd say, after measuring from the takeoff of the SMA down, that we're fairly confident the aneurysm is infrarenal. If it takes off within 2 centimeters of the SMA, then we have to be much more worried about a juxta or a pararenal AAA. And again, that needs to be communicated with the vascular surgeon. Not all of these abdominal aortas are easy to find. There's a study done a number of years ago that found just a little below 10% of abdominal aortas can't be visualized because of bowel gas. Bowel gas is really the enemy in finding the abdominal aorta. And there's a couple ways to maneuver around this. The first one is pressure. Now, I really should say graded pressure. So if you drop your probe on the patient's belly and just jab it in as hard as you can, it's going to hurt. But if you steadily increase that pressure and rock it back and forth, push that bowel gas out of the way, the patient's going to tolerate it a lot better and potentially will really help your image. So this is number one. Number one way to try to get bowel gas out of the way is to gently push it out of the way. You can also reposition the patient, have them roll, see if gravity will help us kind of move bowel gas around and allow us to hone down on that abdominal aorta. There's also some unconventional views you can take. Again, this is a tool, and sometimes tools aren't used perfectly. You gotta find ways around difficulties, right? That's what we do in the emergency department, and kind of taking care of critical patients. Is we sometimes have to use tools in different ways. There's a few views you can get of the abdominal aorta that can really help you find different parts of the aorta without going through all that bowel gas. So if I'm having a really hard time visualizing the abdominal aorta and kind of the transverse midline abdominal view, one of the things I'll do is I'll come over to the patient's right in a more coronal plane, and you can actually image through the liver in some folks, not everybody, in some folks, and find the proximal abdominal aorta through that window. You can also come down in a kind of parasagittal plane, and I'd say probably about the mid-clavicular line, and try to image down to the aorta in that method. We can work on these in our scanning stations, but there are other ways of trying to find that abdominal aorta and assess for at least segmental views to evaluate for aneurysm or not. Obesity is obviously a major roadblock in terms of seeing the abdominal aorta. And in some folks, you just need to know when enough is enough. You're not going to be able to find it with an ultrasound, and you got to move on to different modalities. Moving on to what AAAs look like. This is a crazy picture. You can see this guy's AAA. It looks like it's about to burst through his belly. It's not a good look. This is a study we did not quite a year ago. I like this study because it's got really good view of the spine. In fact, at the midpoint in the clip, you can actually see the spinal canal open up real quick. There's a large AAA here. You can see how big this guy is. And you can see all this mural thrombus. Right? So here's the lumen. This is like the remainder of the lumen. And you got a bunch of mural thrombus. So if we were going to measure this, we would take it from here down to here. Okay. Here's another example. This is more of a static clip. You can see another good shot of that vertebral body. All right, we're sure that this is the aorta. This is pulsatile, obviously. And that aneurysm sac goes all the way around here. Okay. One of the pitfalls, and we'll talk about this briefly later on, is people that look at this and they measure that and they're like, it's okay. Now, this is still pretty big. And hopefully, if you measure this, it would still be above 3, but it does not measure nearly as big as this kind of entire aneurysm sac does. This is a still image of a suprarenal AAA. So we're in the sagittal plane here. You can see the takeoff of the SMA here. Here's the liver. This is hemidiaphragm, and there's going to be cardiac structures up here. You can see this measures over 3 centimeters, right? And if we were going to measure this correctly, I would probably bring my caliper out here, and maybe out here. It would give us probably somewhere about 3.7 centimeters. Regardless, this is a suprarenal AAA. Okay. If you would follow it down here, it would taper down. Most suprarenal AAAs also involve the thoracic aorta as well. So that's something that you want to consider imaging if you're seeing this on your ultrasound image. We're going to focus on ruptured abdominal aortic aneurysms now that we've seen what a normal aorta looks like. We've had a few examples of AAAs. Now, ruptured AAAs are obviously much more concerning than unruptured AAAs. Not trying to diminish the importance of getting someone the treatment they need if they've got a large unruptured AAA. But the ruptured AAAs are really the time-sensitive ones we want to catch and ones we really want to hustle quickly through our diagnostic and therapeutic algorithms. Once again, these are time-sensitive conditions, and we need to get them what they need quickly. My plea to you, my personal practice, is just to take a second or a few seconds and look at that AAA. We're going to talk about some characteristics of rupture. The idea being, if we can communicate to the vascular surgeon that the aneurysm is definitely ruptured based off of our ultrasound, that's going to potentially mobilize things quicker. All right. I am not asking or telling you to hold up transporting your patient to the CAT scanner or to the OR because you want to get a few more clips. But sometimes it takes an extra 30 seconds, particularly if you get good at this, to kind of hover over that AAA, watch it move, and maybe get another view or two that can really help you out. Sometimes a CT scanner is not the right place either. Right? We've all seen patients crash and burn over in the CT scanner. It goes from being the tube of truth to the donut of death pretty quickly if you send an unstable patient over there. Sometimes this is not a reality, and the only diagnostic modality we have at the bedside for this is ultrasound. So again, being able to take a look at that aneurysm and detect rupture versus not rupture can be very helpful. Now the kicker is abdominal aortic aneurysms rupture into the retroperitoneal space. And we know from our FAST exam experience that ultrasound is not good at picking up retroperitoneal fluid, right? Much better at looking at free intraperitoneal fluid, not retroperitoneal fluid. So it's tough to figure out if there is extraluminal blood with ultrasound. Now I'm going to give you a couple ways that you can try to figure out if your AAA is ruptured. So the first thing to do is look at the aneurysm itself. When AAAs rupture, they go from this nice fusiform aneurysmal swelling, if you will, of the abdominal aorta to a much more abnormally shaped vessel. Right? There's been loss of integrity in the portion of the wall, and it will turn your aneurysm again from this kind of nice donut-looking thing into a more abnormally shaped vessel. You can also watch it move. And the corollary to this is essentially a regional wall motion abnormality of your abdominal aorta. So during systole and diastole, it's going to move in a irregular fashion. I'll show you some examples of this in a second. You can also look for a defect in the wall of the aneurysm. Looking in the retroperitoneum can be helpful. We just talked about the fact that ultrasound is not good at looking at retroperitoneal space for fluid, but sometimes there's a couple little tip-offs that you can look for can help. You can also see retroperitoneal hematoma. Not all the time, but sometimes. You just need to A, know what it looks like, and B, take those blinders off and start looking outside of that black hole. And then the third thing you can do is assess the location of the kidneys, and I'll get into how this is done and why it happens in a few slides here. This is a great clip. This is a ruptured AAA. Okay, you can see we're definitely looking at that abdominal aorta. You can see the vertebral body here. Again, you can see a little bit of the spinal canal down here. We are sure that this is the aorta. Right? We have identified this aneurysmal sac here, and we can see a couple things. First of all, this aorta is shaped in this really unusual fashion. It looks like a pear, but it's not nice and round. It moves in this really funny way. Right? You can see it's kind of moving in systole and diastole here, but maybe not so much over in here. So this is kind of that regional wall motion abnormality that I mentioned. Third, you can see a defect in the parietal wall of the abdominal aorta, kind of right in here. So this is where that AAA is ruptured. And it has dumped all of this blood into this retroperitoneal space. Again, if you're looking for that nice anechoic positive fast exam view, you're not going to get it. Right? This is clotted retroperitoneal blood, but this is not something that you typically see when you look in the retroperitoneum. Right? This is unusual. And again, it's very easy to focus just on this guy right here in the center and not kind of open your eyes wider and see the retroperitoneal hematoma. Here's a still. This is a clip showing both hemoperitoneum here in the tip of the liver down into Morrison's pouch, kind of extending at the start of Morrison's pouch at least. But there's also retroperitoneal blood. You can see anechoic fluid in here, right? This is in the retroperitoneum, kind of around that right kidney, and is very suggestive of retroperitoneal fluid in this setting, hemoretroperitoneum. Now, when AAAs rupture, they're going to go generally into one of three spaces. They're going to go into the anterior pararenal space, they're going to go in the perirenal space, or they're going to go in the posterior pararenal space. Now, if the AAA ruptures in the perirenal space or the posterior perirenal space, what's going to happen is it's going to displace that kidney, ipsilateral kidney, anteriorly. I have a few images of some ruptured AAAs here. This is a big ruptured AAA. It has ruptured into this left posterior perirenal space and has displaced this left kidney anteriorly. I noticed this in doing fast exams on ruptured AAAs and trying to find my normal anatomic landmarks and not having great success looking at kidneys. There's no data to back this up. In fact, there's no data where AAAs tend to rupture. No one's really cared about where this actually happens really until now. Um, but finding that kidney anteriorly can be a tip-off that there's something pushing it up there, i.e. a retroperitoneal hematoma. Here is one on the left side, and you can see, this is the right side. You can see right kidney, large right AAA ruptured into that right posterior perirenal space and push that right kidney anteriorly. Okay, so again, this can be a tip-off. There's no hard science behind this, but if you're noticing that that kidney is much more anteriorly than you would expect it to be, it suggests that there's something pushing it up there. All right, a couple examples. It's a large AAA. You can see as we go through the clip, big space, unusual shape to it initially, and probably maybe a little defect over there, hard to tell, definitely some retroperitoneal hematoma in there. This is a patient that I scanned several years ago. She had a known AAA, was an elderly patient, had a syncopal episode and came in PEA arrest. She got a pulse back. It's kind of hard to imagine how. The family was busy talking with vascular surgery about what they wanted to do, and I got a ton of really amazing clips. So this is obviously a large AAA. Is a great spine sign. So we found the spine, AAA on top of the spine. You can see this big defect in the parietal wall of the aorta. And this AAA is leaking intraperitoneally. So that's why this woman had syncope and essentially PA arrest as she bled out into her peritoneum. There's also a large amount of retroperitoneal blood back here. If we put color on it, we can actually see blood being ejected out of the aorta into the peritoneum. So this is pretty rare clip. I was pretty lucky to get this. Pretty amazing imaging. Here's another one. You can see large AAA. You can see kind of unusual shape to it in the middle. See how it kind of turns from round to kind of more ovaloid. It's moving a little unusual fashion. And then there's maybe a break over here in this parietal lumen of the aneurysm cavity, and then most likely some extraluminal blood right here. Okay. Yet another one. This is one we did about a year ago. This is a really great clip because it really incorporates a lot of the things we talked about. You've got AAA, you've got a break in it, right? You've got, this is someone that's in PA arrest as well, but you've got this huge retroperitoneal hematoma off to the right of our screen, kind of right there. Again, you take those blinders off, you'll start seeing these things. Pretty amazing. So once again, to go over findings of ruptured AAA, we're going to look at the aneurysm, we're going to see how it moves, we're going to look at the shape, we're going to look for a defect in the wall. You got to open those blinders up, look for retroperitoneal fluid, look for the presence of hematoma around the aorta, and then bonus is looking at the location of the kidneys. So thus far we've talked about finding the abdominal aorta with ultrasound. We've gone over what AAAs look like. We've talked about what ruptured AAAs look like. And we're going to spend a little time now talking about endovascular grafts. These are being done more and more commonly, particularly in patients with unruptured AAAs. Before I really got interested in abdominal aortic ultrasound, I have to admit I was not completely clear on the difference between an open repair and an endovascular repair. So we're going to go through that very quickly. When someone has an open repair of an abdominal aortic aneurysm, particularly of an infrarenal abdominal aortic aneurysm, the approach generally is an anterior midline incision. The vascular surgeon tunnels their way down, finds the aneurysm, essentially does an aneurysmectomy, if you will, and replaces the aorta with graft. You can see over here they've got these little suture lines in there, so the vascular surgeon sutures like crazy, make sure that there is no leak from the graft, and that is that. The repair is done, and they have essentially replaced the aneurysm sac with the graft. Now, to contrast that with a endovascular repair, things are very different. And the crux of this is that the aneurysm remains in place. They are basically going through an endovascular method with a catheter, using fluoroscopy, etc., and deploying their graft through the catheter proximal to the takeoff of the aneurysm. So the aneurysm is still there, but you've got this kind of graft through the aneurysm sac, which stabilizes it. So you can see there is an inherent difference between the aneurysm being totally removed in an open repair and the aneurysm still being present, but the endograft running through the aneurysm. There are a number of different types of leaks of endovascular graft repairs. I'm not going to delve into the different types, but you can see if this kind of proximal portion pulls down, you can have blood leaking into this aneurysm sac, which can cause enlargement of your aneurysm sac. So a lot of the evaluation of these grafts can be looking at the actual aneurysm sac itself and seeing if that is enlarging. Here's a patient I saw about a year ago. This is a patient with a history of end-stage renal disease or on hemodialysis. He had an endovascular AAA repair previously done. He came in with hypotension and near syncope. Had no pain, but we wanted to make sure that that aortic graft looked okay. You can see here is the aneurysm. The aneurysm is still present. You have a little bit of vertebral body back here. Not super clear, but you can see the components of the graft within the aneurysm sac. So measuring the graft components is not going to be of any help. Right? The Gore-Tex or whatever material they're made of, they're not going to enlarge. But measuring the sac, again, can give us information. If the sac's getting bigger, well, that's concerning. So we were able to measure the aneurysm sac. We were able to compare that to recent dimensions on CT scan. It looked okay. We said, hey, you're probably going to be okay, and sent the patient home. To contrast that, this is a case of an endovascular graft leak. So here's a patient. You can see there's an aneurysm sac. Here is the endovascular graft right here. There's color Doppler on here, and you can see color flow within the grafts. But this is quite large and looks a little unusual. There are some bright echoes in there. I'll show you a still. Now, this is not the measurement, again, we want to take. The measurement we want to take is this, right? Measuring the entire aneurysm sac, and you can see vertebral body over here. Here's the patient's CAT scan. And the patient ended up getting a contrasted CT scan, and you can see following the aorta down, here's the graft material. There is contrast, extravasation into the aneurysm sac, signifying that there is graft. There is an endo leak present. Now there's some other stuff going on, obviously, in the patient's liver there too. So to reiterate, you can still look at that sac in a patient with an endograft repair. If it's bigger, that is really concerning. Okay. So we're going to change gears and talk about aortic dissection. In particular, obviously, we're going to talk about ultrasound for the diagnosis of aortic dissection. Just to review and make sure everyone's on the same page, there are two major classification systems for aortic dissection. Number one is the DeBakey classification, and number two is the Stanford classification. These seem to be used pretty interchangeably. When you read about this, some people use DeBakey and other people use Stanford, and there doesn't really seem to be much rhyme or reason to that. The crux of this is that a Stanford A involves the proximal aorta, and a Stanford B involves only the distal aorta. The DeBakey is kind of one more step complicated. The DeBakey 1 involves the proximal or ascending, the arch, and the descending. The DeBakey 2 only involves the ascending, and the DeBakey 3 only involves the descending. So there's a clinical policy that ACEP put out a few years ago about the diagnosis and management of patients with suspected thoracic aortic dissection. This is a great clinical policy and addresses a lot of the issues that we have when we are evaluating and managing patients with suspected acute non-traumatic thoracic aortic dissections. I really want to highlight two of the recommendations that they had. The first one is a level B recommendation that states that you shouldn't rely on an abnormal bedside TTE to definitively establish the diagnosis of thoracic aortic dissection. I think most of us would agree the gold standard for diagnosis of thoracic aortic dissection is a CT angiogram of the chest, or perhaps a TEE. Probably can throw an MRA into that group as well. Those are really the diagnostic tests. An abnormal bedside TTE is really suggestive of thoracic aortic dissection, maybe not definitively like the other tests we mentioned. However, if you're seeing abnormalities on your bedside TTE, and we will get into these in a few slides here, you should immediately start to think about next steps. Their level C recommendation includes immediate surgical consultation or transfer if that's in your protocol if the TTE is suggestive of that thoracic aortic dissection that you were concerned about. What findings are these? Well, pericardial fusion is a big one, as is aortic root dilation. We are not going to talk about these. That's much more of a point-of-care echo talk. I am going to throw in the suprasternal notch view in here just to make sure it's covered, and we'll talk about some abdominal views. The suprasternal notch view is not part of people's typical point-of-care echo examination. However, it's not that hard to do, and in the right circumstance can be really helpful. What you're going to do is you're going to take your phased array probe, or i.e. your cardiac probe, and you're going to put that probe in the patient's suprasternal notch. Okay? You have to have the patient hyperextend their neck and point their jaw up towards the ceiling, and you have the indicator notch aimed towards the left jaw or the left shoulder. Unfortunately, you kind of have to push a little bit to get this view. You really have to kind of square that transducer up, kind of making it as parallel as you can to the trachea. This doesn't feel very good, so you definitely have to warn your patient. So again, once again, this is how you do it. Find that suprasternal notch, put your phased array probe in there, notch towards the indicator, notch towards the patient's left shoulder, and this is what you'll see, ideally. So this view is not quite the same as the cartoon. It's a little angled, but we can see the ascending aorta here, the arch into the descending aorta. And you can see the takeoff of the great vessels right here. This is a patient I had about a year ago who came in with chest pain radiating to his back. We took a look with our echo probe. His peristernal and apical views looked okay. We switched up to a suprasternal notch view, and this is what we saw. So you can see again, this is ascending aorta, arch, and descending. And you guys can see this echogenic flap here moving with systole and diastole. So this guy had a Stanford B or a DeBakey 3 aortic dissection. Here is an abdominal view showing extension of that thoracic aortic dissection into the abdomen. You can see, again, this hyperechoic flap that's moving systole and diastole, so there's some movement to it, right? Here's the diaphragm. This is going to be liver up here, and that flap is extending in a cephalocaudal direction. You can see the takeoff of the SMA here. It looks like it kind of takes off right into where that SMA takes off. Put color on it. You can see this is the true lumen, and then this is the false lumen here. not too hard, right? If you take the time to look for this, you'll find it in the right scenario. This is a case we had probably about 2 years ago of a patient that came in with inferior STEMI on their EKG and altered mental status. And the folks that took care of this patient did a really great job in recognizing that she looked a lot worse than an inferior STEMI tends to, in terms of, at least in terms of her mental status. You can see in this EKG, there's inferior ST elevation with some lateral, reciprocal lateral ST depression here, as well as some depression in B2. They called our cardiology service. Cardiology came down, saw the patient, and something just kind of didn't smell right. So the emergency medicine folks grabbed our point of care ultrasound machine, and this is what they saw. So this is very similar to the view we just saw. You can see cardiac structures up here. Here's liver, and you can see this mobile echogenic flap moving with systole and diastole. Right. Incidentally, if you look down here, there's also a AAA. So this person had a dissection and an incidental finding of abdominal aortic aneurysm as well. This is an echo view, and I know we have not touched on point of care echo, but I do want to show this as a pretty amazing view. This is a parasternal long axis view. So to march through this, you've got right ventricular outflow tract, you've got your left ventricular myocardium here. This is actually descending thoracic aorta right there. You can see the left atrium, mitral valve. Right here is the aortic valve complex, and you can see this mobile flap is moving back and forth. This also looks really big. My suspicion is that she's got dilation of her aortic root, which you see not uncommonly in patients with aortic dissection. Notably, there's no substantial pericardial effusion here, which is one of the things we talked about earlier. So this patient, instead of going to the cath lab, getting heparin and Plavix, she went to the OR. Very drastic change in her management. And what had happened is she had a Stanford A dissection, which had dissected back into her right coronary artery, causing her to have an inferior STEMI pattern on her EKG. There's pitfalls to this, as always. One of the main pitfalls that I have run into is artifact. So this is a sagittal view of the abdominal aorta. You can see liver up here. Again, this is takeoff of her superior mesenteric artery, head and feet down here. You guys see this echogenic line right there? Right? It looks like a dissection flap, but it just kind of comes out of nowhere. So this is an artifact that we started noticing when we were scanning a lot of folks looking for dissection. And we tend to notice it right here after the takeoff of the SMA. We CT'd a lot of these people and found that they just had a very heavily calcified aortic wall. No aneurysm, no dissection, just calcification. And what I think this is some kind of mirror image artifact, or reverberation artifact that is causing this line to pop up. Now you'll notice compared to the previous views where we saw a true dissection flap, this kind of just pops up out of nowhere. It's not contiguous with the proximal portion of the aorta. We put color on there, and you can see it's kind of strange, or there's flow on both sides, and it just kind of drops off right where that artifact is. There's another machine. You can see it right here, right? Take off of the SMA, that artifact just turning from sagittal to transverse, and you can see it kind of maintained in the transverse view right there. So just be careful with that area below the SMA. If you see that line there, you should make sure that if there's a dissection flap, it should be contiguous with the more proximal portion of the aorta. We're going to move on and talk quickly about pitfalls. Like any point of care study, there are ways that you can get yourself in trouble. And like most of these ways, it's by not understanding what you're looking at, not understanding the anatomy, not understanding the technology that you're using. This is a great image. I really like this image because this really looks like a big AAA. I mean, you can look at this, be like, oh my gosh, this is uh, almost 10 centimeter AAA. There's mural thrombus there. The blood's probably going to be perfusing around here. This is not a AAA. One of my colleagues had a case just like this. He had a patient that rolled in to his emergency department. He plopped the ultrasound transducer down. The guy was rolling around, complaining of abdominal and back pain. He saw something that looked very much like this, and he called and transferred the patient out with a diagnosis of the symptomatic, if not ruptured, AAA. So if you take a look at this image, the one thing you're not seeing is the spine, right? As we talked about earlier, you need to find the spine. We don't see a spine here, right? This is an easily solved problem. This guy got a Foley catheter and went home, right, after he got to the receiving facility. Now this is a urinary bladder, and this is a clot inside the urinary bladder. So this is way down in the pelvis, and sometimes these folks with really distended bladders, they can kind of really encroach up into the abdomen, but we're not seeing that vertebral body, right? That vertebral body really is key to diagnosing that aortic aneurysm, or at least identifying the abdominal aorta on ultrasound. All right, another pitfall that we see occasionally, and we kind of touched on this earlier in the lecture, is failing to measure the outer wall to the outer wall. So here's a still of an abdominal aortic aneurysm. You can see that vertebral body. We know that this is a AAA. Every once in a while, we will see someone measure it like this. As we talked about, that is the remnant of the lumen. This is the aneurysm sac. So what we want to do is not measure the lumen, but measure the aneurysm sac. And you can see how it'd be very easy to do this if you're not fully aware of what's going on. So measure not the lumen, but the aneurysm sac. This is a case from not quite a year ago we had. This lady came in with abdominal and back pain. Folks taking care of her were worried about the possibility of a AAA. They threw the ultrasound probe down. They are seeing vertebral body back here, and they're seeing this big mess going on in the patient's abdomen. So we've looked at a number of different cases where we've seen this kind of complex mural thrombus. I will tell you that her abdominal aorta is quite small and it's actually right there. All right, so her abdominal aorta is not aneurysmal. All this extra stuff is actually retroperitoneal lymphadenopathy. This patient has significant lymphadenopathy from a new diagnosis of lymphoma, not an aortic aneurysm. They ran her through the CT scanner and confirmed this, but with the use of some Doppler, they were able to kind of troubleshoot this and say, okay, well, we still need a CT here, but we don't need to, hit all the bells and whistles here. All right, some future considerations. I bring this up because I think we're really at a crossroads. We're hearing more and more about the use of artificial intelligence and scanning protocols and helping us with making diagnoses, making point of care ultrasound easier. And I think we're going to see more and more of this come down the road. Most folks will recognize this. This is a reconstruction from a CT angiogram of a large, kind of lumpy looking abdominal aortic aneurysm. The reconstructions of some of these CT scans are amazing if you take the time to look at it and really kind of parse through the different images. It is amazing the detail at which you can see what's going on, and you can really start to understand why surgeons are so interested in getting these CTAs, right? Especially vascular surgeons, it helps them so much in planning, preoperative planning, how they're going to attack and find the best way to fix some of these complicated aneurysms. I'll bet you down the road we are start to have more and more the use of 3D ultrasound as these computing power gets more and more portable. We're going to start to see 3D reconstructions, right? You put your ultrasound probe down, and on your screen, poof, right? This is nowhere near technology that's available today, but I'm guessing that it won't be too far off when we really start to see these kind of really amazing 3D reconstructions that are available on point-of-care platforms. Contrast is another advancement that's been made. Contrast is used pretty extensively by cardiology. The folks at our hospital really like using the contrast to help them delineate the left ventricular function, like left ventricular cavity size, and any abnormalities like apical thrombi. It can be very helpful. There's a couple different brands. Again, I don't take money from any of them, but it's kind of amazing the enhancement that you see when some of these are used. They are being used more and more in emergency departments, particularly in Europe and some places in the United States. Probably the most common use scenario in the ED is, at least in trauma patients, particularly pediatric trauma patients. It can be really, really helpful to diagnose solid organ injury without CT. Anyhow, in regards to abdominal aortic ultrasound, this can be really useful in the diagnosis of endo leaks. So this is a patient with an endograft in place that's received contrast. So you can see the aneurysmal sac here and the endograft here, and there is contrast. There are microbubbles outside of the endograft, meaning that they have an endo leak. This is used at times when patients are having their endografts evaluated with ultrasound, but the more comfortable we get with contrast is something we can do at the bedside quickly and easily, potentially in the future. I do want to touch on the idea of ROBOA. ROBOA is a technique, procedural technique that is used predominantly in the trauma setting. ROBOA stands for resuscitative endovascular balloon occlusion of the aorta. It essentially is a minimally invasive technique that allows for occlusion of the aorta. So again, in the trauma setting, this can be very helpful. It is being done at some kind of select trauma centers, particularly in the setting of pelvic fractures and occluding the aorta, allowing the pelvic fracture to be stabilized, and the balloon then taken down, or whatever the treatment algorithm. So when you read about ROBOA, you'll read about these different zones of the aorta. And for ROBOA, the aorta is divvied up into 3 different zones. So the lower portion, the infrarenal portion of the abdominal aorta has been termed zone 3. The mid portion involving the renals and the SMA is zone 2. And zone 1 is above the SMA, kind of into the descending thoracic aorta. So what ROBOA does is, if you have some bleeding in the abdominal aorta, you can thread a guide wire or catheter in and deploy a balloon to occlude the aorta. Now this inherently leads to questions of, can I use this in a ruptured ectopic pregnancy or a ruptured abdominal aortic aneurysm? Most of the studies, most of the data looking at this has looked at the use of this in trauma patients. In fact, the American College of Surgeons just came out with a joint statement with ACEP regarding the use of ROBOA. It is basically a who, what, where, when, why statement paper. The crux of this is that it should be done by trauma surgeons or people with advanced critical care training. The major issue when this balloon is deployed and the aorta is occluded is that the problem needs to be fixed, obviously, as soon as possible. This is a salvage procedure. The downstream reperfusion injury that you'll have, kidneys, and everything else that is supplied arterially from the level of the aorta that's occluded is a significant concern, and these need to be in place for a very short amount of time. It is not prime time for emergency physician use outside of the critical care trauma arena at this point, but it's pretty attractive procedure thinking about treating these ruptured AAAs, right? Because it'd be pretty nice to be able to throw an art line in, thread your Reboa catheter in, occlude the aorta, and stabilize the patient. There are some retrospective studies that have looked at patients with ruptured AAAs that these have been placed, and the data is pretty mixed at this point. So I do think there is more to come on this, but we shall see. When you read about this procedure, one of the major problems is cannulating the femoral artery. The good news is everyone here is going to be super facile at using ultrasound, and this certainly can make this procedure a lot easier if you're seeing where the femoral artery is on ultrasound and using your ultrasound to cannulate that. So kudos to you. All right, quick review. Ruptured AAA is a bad thing to have. Right? We talked a lot about the demographics. Who gets this? Elderly folks, but you still need to worry about it in younger folks, at least middle-aged folks. Doing things to decrease timestamps is important, right? Getting your patient diagnosed and to see the right people is really important. When we're physically doing abdominal aortic ultrasound, you need to find the spine and then sweep the aorta. Again, this can be done very quickly, but you need to find the spine. We looked at that major pitfall of looking at the urinary bladder. If you haven't seen a patient who is writhing around diaphoretic in bed because their bladder is so full, these folks can look like a ruptured AAA. You haven't seen enough patients, and you will see someone that looks like that at some point. So you just got to be careful. The aortic sweep, once again, can be very quick. Up, down, you're done. You see the aorta in its entirety, the patient's not going to have a AAA. We talked a lot about what abdominal aortic rupture looks like on ultrasound. We talked about looking at the shape of the aneurysm. We talked about looking at the wall, looking for a crack, looking at the wall motion. We talked about where to find fluid or hematoma. We also talked about looking at the position of the kidneys. When you're ultrasounding someone with an endograft, you still can use the diameter of that aneurysm sac as a surrogate marker for endograft leak. And last but not least, we talked about abdominal aortic dissection. It's a clue. It is not definitive, but sure can help you ratchet up your concern and get the patient to the right diagnostic modality and down the right treatment algorithm. All right, well, I'm looking forward to scanning with you guys, doing some bedside aortic ultrasound. I hope you enjoyed this. Again, I think this is a really important topic. It can really help you take better care of your critically ill patients. Thank you very much, and see you in Cleveland.